Heart failure is a progressive clinical syndrome where structural or functional cardiac abnormality leads to reduced cardiac output or elevated filling pressures. It carries high morbidity, mortality, healthcare burden worldwide. The AHAL defines 4 stages of heart failure progression from risk to advanced disease. Stage A includes patients at risk but without structural heart disease or symptoms. Risk factors include hypertension, diabetes mellitus, obesity, atherosclerotic cardiovascular disease, and cardiotoxic exposure. Stage B represents pre-heart failure with structural abnormalities like reduced left ventricular ejection fraction, hypertrophy, chamber enlargement, or elevated natriuretic peptides without symptoms. Stage C is symptomatic heart failure with prior or current symptoms such as dyspnea, orthopnea, or fluid overload due to structural cardiac disease. Stage D is advanced heart failure with refractory symptoms, frequent hospitalizations, and need for specialized therapies like inotropes, left ventricular assist devices, or transplantation. Heart failure is classified by left ventricular ejection fraction into reduced, mildly reduced, improved, and preserved categories. HFrEF is defined as ejection fraction less than or equal to 40% and is the primary target for guideline-directed therapy. HFpEF requires preserved ejection fraction greater than or equal to 50% plus evidence of elevated filling pressures and compatible clinical features. Diagnosis can be supported by the modified Framingham criteria, requiring either 2 major or 1 major plus 2 minor features. Major features include paroxysmal nocturnal dyspnea, orthopnea, raised jugular venous pressure, pulmonary crackles, S3 gallop, and acute pulmonary edema. Minor features include ankle edema, nocturnal cough, exertional dyspnea, hepatomegaly, pleural effusion, tachycardia, and weight loss with diuretics. HFpEF diagnosis requires symptoms, preserved ejection fraction, absence of major valve disease, and evidence of elevated filling pressures. The H2FPEF score uses obesity, atrial fibrillation, age above 60, antihypertensive use, elevated E over E prime, and pulmonary pressures to estimate probability. Epidemiology shows rising heart failure burden with increasing hospitalizations and a shift toward preserved ejection fraction phenotypes. Major risk factors include hypertension affecting over 100 million individuals, diabetes, obesity, and established atherosclerotic cardiovascular disease. Common etiologies include ischemic heart disease, long-standing hypertension, valvular disease, cardiomyopathies, myocarditis, toxins, and infiltrative disorders. Clinical assessment focuses on congestion signs like jugular venous distension, orthopnea, peripheral edema, and hemodynamic instability. Initial investigations include complete blood count, renal function, electrolytes, thyroid profile, liver function, and electrocardiogram. Natriuretic peptides like BNP and NT-proBNP assist in diagnosis, prognosis, and risk stratification in heart failure. Imaging begins with chest X-ray and transthoracic echocardiography to assess structure, function, congestion, and alternative diagnoses. Ischemic evaluation using stress imaging or coronary angiography guides revascularization decisions in selected patients. HFpEF management focuses on blood pressure control, SGLT2 inhibition, atrial fibrillation management, and selected use of mineralocorticoid antagonists. HFMREF and HFIMPEF require individualized therapy with continued guideline-directed medications to prevent relapse and progression. Non-pharmacological management in symptomatic heart failure includes sodium restriction, fluid management, vaccination, education, and multidisciplinary care. Structured exercise and cardiac rehabilitation improve functional capacity, quality of life, and reduce hospitalizations in stable patients. Barriers such as depression, frailty, low health literacy, and social challenges must be addressed to improve adherence and outcomes. Guideline-directed medical therapy for HFrEF includes angiotensin receptor neprilysin inhibitor, beta blockers, mineralocorticoid antagonists, and SGLT2 inhibitors. Angiotensin receptor neprilysin inhibitors reduce mortality and hospitalization and are preferred over ACE inhibitors when tolerated. Beta blockers such as carvedilol, bisoprolol, and metoprolol, succinate, improve survival and reverse remodeling when titrated carefully. Diuretics relieve congestion, but do not reduce mortality, and must be adjusted based on volume status and renal function. Mineralocorticoid receptor antagonists and SGLT2 inhibitors reduce hospitalization and mortality and are essential components of therapy. Ivabradine, digoxin, and vericiguat are additional agents used in selected patients with persistent symptoms despite optimal therapy. Device therapy includes implantable cardioverter defibrillators and cardiac resynchronization therapy to reduce sudden death and improve symptoms. Coronary revascularization with bypass surgery improves long-term outcomes in selected patients with ischemic cardiomyopathy. Valvular heart disease and heart failure requires multidisciplinary evaluation, with interventions considered after optimization of medical therapy. Acute decompensated heart failure requires rapid assessment of congestion and perfusion with intravenous diuretics and hemodynamic stabilization. Cardiogenic shock requires inotropes and may need mechanical circulatory support or urgent transfer to advanced care centers. Stage D advanced heart failure requires referral for transplant evaluation, ventricular assist devices, or palliative inotropic support. Comorbidities like anemia, diabetes, atrial fibrillation, sleep disorders, and hypertension significantly influence outcomes and must be managed actively. Final takeaway is that heart failure is a progressive but modifiable syndrome where early detection, staged therapy, and multidisciplinary care improve survival and quality of life.